Okay, thank you, Stefan, for introduction. Dear colleagues, disclosure. As you can see here, the atrial septum is not just a smooth and flat wall. There are differences between the right and left atrial aspect. And ASDs, and this is the major topic in my talk, are caused by an insufficient development of the septum primum and insufficient closure of the septum secundum. So I will not talk on the other side. My task is the right side. So this is true anatomy, right side view to a, is this the pointer? Sorry, I have to, how is this working? I've just done it. Okay, I think it works without. Yes, and the oval fossa here on the left panel is perforated by multiple defects, and an additional small vestibular effect is shown as well. And on the right panel, there's a typical true primum defect and additional oval fossa perforations as well. Besides the anatomy and the size and location of the ASDs, the direction depends on the pressure difference between left atrium and right atrium if the defects are small. And this is other in unrestricted large ASDs where the RV to LV compliance determines the direction. And usually in normal hearts, this is a ratio of 3 to 1. So even in large ASD, this cannot be exceeded, 3 to 1. And if you find that, you have to look for additional lesions, additional shunt, or diastolic dysfunction of the left ventricle. That's not my talk. Okay. Children and adolescents are usually not symptomatic, and maybe there's a murmur. I think this is well known, and ASD closure is indicated in RV volume overload, overcirculation, and this is usually consistent with this shunt ratio at least 1.5 or more. And if you don't have oximetry measurements, then ASD sizes at least 8 millimeters or more in children and at least 10 millimeters or more in adults are accepted as well nowadays. Untreated ASDs are associated with increased morbidity and mortality, and they often result in RV failure. And if moderate pulmonary hypertension occurs, this has a tendency to worsen and arrhythmias become more common. However, severe pulmonary arterial hypertension without or with shunt reversal is infrequent or even rare. Life expectancy for corrective surgery or interventional closure in childhood has a normal life expectancy, and this is the reason why it's routine nowadays to close the ASD in childhood. Today, interventional and surgical outcomes are similar, and but we have to have in our mind that if complications occur during interventional closures, then this is an emergency unplanned surgery with a higher mortality and morbidity. However, transcatheter closure is the therapy of choice, and we can close 80 to 90% of the ASDs we find. Currently, the following devices are available on the European market, and all of them are double disc devices, so they have a left disc as well, but I don't talk about that. Their rigidity and integrity is the subject of an ongoing debate about erosion. I think this is well known as well. So I stated already 80 to 90% is the closure rate we can get with these devices. But what about the 10 to 20% that we cannot close? I found a study from Toronto with 639 children concerning this topic, and 52 out of this series were patients where the device closure failed or was refrained, and 82 of them were directly sent to surgery. And the most often difficulty was the deficient rim and especially the inferior rim, or too large defects, multiple ASD much less, and some other reasons. This is very interesting, ASD too small. How can this happen? This is typical for, I think, pediatric series, because most of, this is a patient from our outpatient department, most of the children diagnostic echo before is without TOE, so the same patient here in the cath lab, no indication, no intervention indicated, so this can happen. Yeah. Here it's very clear to see by transthoracic echocardiography that this defect is very large and the rims are pretty small, and this is not suitable for interventional closure, in my opinion. What is a large ASD? Mostly it's said that defects at least 20 millimeters, 25 millimeters or more. Large defects, this is a size what a child of 2 years never has. That's maybe the total septal length you have. As an example here, 2 year, this girl old, body surface area 0.5, ASD diameter around 15 millimeter is a large ASD with 30 millimeters per square meter, and 15 is far away from 25, of course. And in this case, it was possible to close this with a device, and whenever you close these large defects, you have to take in consideration that the device will cover the whole septum in this patient. Yeah, anatomical limits. It can be quite difficult to reach the atrial septum and the defect if the vena cava inferior is interrupted as a congenital lesion, or has an abnormal course, or is stenotic occluded. You may need transjugular or transhepatic access. This is described, or as in Leipzig, in this case, performed, you can stay on your transfemoral route and go via the Erzeugus vein and close the defect. But I think it's not that easy to perform this. Or you chose for a limited right-sided thoracotomy. This is a typical example, difficulties to get access. A girl here, aged 4 years, with a long hospital stay in the beginning due to esophageal, duodenal, and anal atresia. Iliac vein stenosis from central venous lines were the reason, and it was possible to get up to the heart. Cutting balloons were used, and finally a balloon that dilated the vessel to bring up a long sheet, sizing the defect and implantation of an, in this case, Amplatzer device. Similar case here, similar, bit different. It's a post-giant Omphalothele with an abnormal IVC course. It was possible for me to get to the left atrium to balloon size, but I couldn't bring up a device, so we chose for the transjugular axis. This is also, and it's not that attractive way to the atrial septum. Here we used a pigtail catheter for guidance. I think you can use steerable sheet or other techniques to make this easier. Sometimes it's easier to get to go transhepatic. In this case, it was possible to advance the delivery sheet and to implant another Amplatzer occluder. But you see on the enormous release jump the device makes when the angulation there is difficult. Other anatomical limits are from the fetal or embryonal period, the Eustachian valve, Chiari's network, superior vena cava ostium, the Tibesian valve, and I found an incomplete core triatriatum dexter as possible reasons, but it's stated that Chiari's network and vena cava superior and Tibesian valve usually are a real obstacle. Here's a case below from Gianfranco Butera, where you see that the the right atrial disc of this PFO occluder is tackled here from the Eustachian valve, and finally they found a solution to push it away with a pigtail catheter and close the foramen ovale. This is one of our patients with a prominent Eustachian valve, but it was possible sometimes it's better to develop the device very quick on the right side, and then it's possible to avoid this, that the valve entangles the right atrial disc, like in this case, no obstruction here. And this is from our OR TOE with an incomplete quadriatum dexter I found a few days ago. You really have the idea that this can be very difficult if you want to see which hole has to be closed. It's the same patient. There is a communication, and it's fibromuscular tissue there that can make interventional closure, I think, really difficult. This was operated on surgery. Yeah, we had a case in our cath lab with a superior vena cava barrier here. See that very nice on the echo, I think, that the right atrial disc cannot adapt to the septum. Carefully use the snare to get away from that, and a balloon, and the result finally was very nice. Better seen or shown here on echo. So it was possible to get rid of this, but this can be difficult as well, especially for devices as here, where the right atrial disc is as large as the left. Yeah. So maybe as an Amplatzer device or similar would have been maybe an advantage, but there was not so much rim at the top of the roof. So this result is good in this case. Yeah, here I show a very typical ASD in a boy aged 8, and I think that most of you see that this is not a standard case because there is too much red color here. This is a bidirectional shunt over the ASD, and this is what I, when my talk began, said you have to be aware that the function of the right ventricle, the compliance of the right ventricle is very important if you talk about the shunt direction in larger holes. So this is a boy after or with pulmonary atresia, intact ventricular septum, who was treated just by opening the outflow tract, and he still had good catch-up growth of the right ventricle, but the ventricle is not normal, it's restrictive, and the pressure traces show that there is some diastolic dysfunction, and the patient had cyanosis, so test occlusion was performed. You have to be careful when you perform that. Do that long enough, is that what, and not very quickly to get all these measurements you need for a decision. But in this patient, it was possible to see, or it was easy to see that the sets went up, and the hemodynamics didn't change. So we could close that and note that the right ventricle really is not normal. The musculature is explains that you have here a diastolic dysfunction. The complete closure of the defect was well tolerated, no clinical sequelae and follow-up, but it can be worse, and you have these borderline hemodynamics, these patients where it's maybe not allowed to close the hole completely, and a fenestrated patch or device may be a good solution, as we had in this patient here, 78 years old, ASD with pulmonary arterial hypertension and atrial fibrillation as well. And he had severe exercise-related dyspnea and no acquired other coronary or valvular heart disease. And you see that the right atrium is quite dilated and ventricular performance maybe not that good. And QPQS was still more than 1.5, 2 to 1. So in this case, we decided to implant such a fenestrated device, what was well tolerated during the intervention. The elevated
pulmonary arterial pressures didn't drop, but what we saw on follow-up that the patient improved and his exercise exercise capacity was much better, and with success in this case. Sometimes it's good to have an ASD. This is an example for that, where ASD creation was very helpful to get access to pulmonary veins on the left side with a RF wire system to dilate the pulmonary veins, and this is the other way around. So sometimes it's good to have an ASD, of course, and I think there are a lot of examples you could show here. So I'd like to conclude that today device closure of relevant ASDs is considered therapy of first choice. The success rate is 80 to 90%. Systemic vein anomalies or anatomical barriers within the right atrium may make it difficult to access. However, these conditions are rare. And in patients with restricted right ventricles or ASD with pulmonary hypertension or both, test occlusion of the ASD is mandatory before considering closure. Thank you.